Hi, everyone. It's Denise Wilson, and I want to welcome everyone to the Payer Watch and Adam combined webinar on Medicare Advantage denials and abuses, a provider call to arms. So glad you all could meet with us today. We're going to go about an hour and 15 minutes just to make sure that we have plenty of time for questions and answers at the end, because we've got a great panel of speakers today. I'm going to just host and moderate for the most part. And well, I am going to present some of it as well, but my piece is not nearly as interesting as our guests that we have on the call today. So very happy to have Dr. Brian Moore from Atrium Health, Dr. Kendall Smith from Payer Watch, Bill Haynes, attorney at Payer Watch, and then myself as well. Now, if you are new to GoToWebinar, you should have a little panel that popped up when you signed in, and that panel will have a drop down that says Handouts, and if you click on that Handouts drop down, you'll be able to download the slides for today's presentation. We also are providing a templated letter for you to use if you'd like to make your comments to CMS about the 2024 proposed rule. You can download that from there as well. Also, if you go to the ADAM website, which is ahdam.org, just scroll down a little bit on the home page. You can also download the slides from there and the templated letter from there as well, because I know sometimes, you're behind a firewall, it won't let you download from the pop-up from GoToWebinar. Also, if you're watching we have our cameras on, you'll see I'm listed as Brian McGraw and Dr. Smith is listed as me, so sorry about that, but I think you know who's who, so that this should not be confusing. So today we're going to talk about CMS's.
Denise is not nearly as unattractive as your picture right now would show.
So CMS, if you're not aware, and I'm going to go through a little background on this, they published a proposed rule on Part C Medicare Advantage program, and comments back from interested parties, that's all of you on the call today, are due back to them by February 13th. And so, as I said, we've got a great panel today that's going to talk about some key takeaways from the proposed rule and leave you with a call to action. We're going to talk about this again on February 1st when our special guest is going to be Dr. Eddie Hugh, and he's going to give us his key takeaways and his perspective on the proposed rule. So if you've registered for today's, you're already registered for the one for February 1st. You don't need to register again. If you haven't registered for the February 1st presentation, you can do that on the ADAM website. You can also do it on the payerwatch.com website. So it's payerwatch.com or ahdam.org website. Okay. Dr. Brian Moore is Chief Medical Officer and Physician Advisor at Atrium Health. He's a national leader and advocate on Medicare and Medicare Advantage issues. And he's a board certified in emergency medicine, a member of the American College of Physician Advisors. Just love having him with us and listening to him speak. Dr. Kendall Smith, he's a senior fellow in hospital medicine. He's our chief physician advisor for Payer Watch and Appeal Masters, and he's a leading appeal educator for appeal services. He has served as a physician leader on hospital revenue cycle management teams, also as a physician advisor for clinical resource management. He's a HEMA ICD CM PCS approved trainer and ambassador. And Bill Haynes is the managing attorney and legal director of the clinical legal unit for Payer Watch. He's a member of the in good standing of the Maryland Bar. He's a member of ADAM and a member of Health Law Association. So his experience is in healthcare law, including managed care contract analysis, payer provider arbitrations, and independent review process. So we always appreciate his input onto these legal matters when we're talking about regulations and regulatory statutes. And then me, I'm Senior Vice President at Appeal Masters and Payer Watch and President of the Association. Been in healthcare for over 30 years and in denial appeal management for about 17 years. My background is nursing. I do a lot of education and speaking these days. If you're ever looking for an educational session or a speaker for any of your groups that you might be a member of, or for your hospital, let me know. Okay, so a little bit of the background before we get into our talk. Going back to April of last year, which isn't that long ago, we were just talking about how quickly this has kind of moved through the process. We don't usually see things move this quickly. So there was an OIG report that came out in April of last year that talked about how the Medicare Advantage organizations are using clinical criteria that are not contained in Medicare coverage rules. And they said in that report that CMS guidance is not sufficiently detailed enough to determine whether MAOs can deny authorization based on their internal clinical criteria that go beyond Medicare coverage rules. So this is nothing new to us who are working in the field. We have known this for years and years. And it came out in this OIG report, and now it feels like things are kind of moving to address that mismatch between what MAO is doing and what maybe Medicare had intended for them to do. So in August of 2022, then CMS sent out a request for information, and they were seeking feedback from providers as well as patients on ways that they could strengthen the Medicare Advantage programs and to create more opportunities for stakeholders to engage with CMS. So they received 3,986, almost 4,000 comments back from providers as well as from patients as well. If you're interested, if you weren't part of that, forgot about it, whatever, I've got the URL there. You can go and read some of those comments. So that's still up and available for you if you're interested. Then in December, so they just issued that in August. So 4 months later, they came out with a proposed rule, and that is, in my experience, pretty quick to come out with a proposed rule just 4 months later. So that was published December 27th, and it's, if you want to refer to it, CMS 4201-P. And the proposed rule would codify existing Part C and Part D sub-regulatory guidance. And I know Bill's going to talk about that in a little bit of detail, but I know Brian and Kendall are probably going to mention that as well. The part of the proposed rule, so there's 12 provisions in that proposed rule. The one that we're talking about today and that we're most interested in is provision E. So they're not numbered, they're alphabetized. E is utilization management requirements, clarifications of coverage criteria for basic benefits and use of prior authorization. Okay, so that's the one you want to hone in on because it's a long proposed rule. So if you go to provision E, I think that's the one you're going to be most interested in. As I said, comments are due by February 13th, and then I have where you can find the proposed rule in the Federal Register. Okay, that's a really long link. You can also just Google CMS-4201-P and find it that way as well. Okay, so I'm going to turn it over now to Dr. Brian Moore and let him talk to us a little bit about his take on the proposed rule and what he'd like for us to know about it. So, Dr. Moore?
Yes, thanks, Denise. I mean, this is a big step forward for, I think, the battle that we've been fighting with the variance in coverage, or at least applied coverage for Medicare Advantage for covering the basic benefits of Medicare. And I think that the most important thing that they clarified was what did they mean by coverage of basic Medicare benefits. And it's essentially everything that is considered a basic benefit has to be covered by the MA plan. And we've talked about this in many different webinars about these basic provisions, but really the level of care or site of service, it was unclear if the inpatient benefit or where somebody received a service was really meant to be a coverage benefit, or if that was able to be covered in a different manner through Part A and Part B services, or even outpatient observation for instead of an inpatient. And this appears to make a clarification that they consider the site of service and inpatient level of care as a basic benefit. And why that's important is, as many of us have tried to fight this fight, is If it wasn't a basic benefit, if it was really more just a utilization management decision, but they were still getting a hospitalized benefit, hospitalization benefit, but it was as an outpatient instead of an inpatient, then often what we have found is that when you appeal these at the time of the authorization, that appeal gets dismissed because it's really determined to be a claim or payment issue, as opposed to it being a basic benefit. So it's a pre-service benefit issue and a determination or a concurrent service determination. And this clarification, the proposed clarification, and I think that it's not ideal, but it seems to clearly identify that CMS did not intend for the basic benefit, and they called out specifically that the inpatient level of care and also post-acute levels of care are something that they consider to be a benefit that's about the basic benefit. So this is an area where the new dismissal language that came in the update for the Medicare Managed Care Manual in August, I believe it was, would mean that you might be able to remand this dispute back to the plan if you get it to Maximus or the independent review. So just realize that that's why this is important, because this isn't really a contractual argument. It becomes a benefit argument, and it's a basic coverage right that's established, and that Medicare Advantage should be covering it. And the other thing that was really clear, and I think Eddie had pointed out in his research, but it's page 130 to 165 are the key pages to read about the utilization management. But they talk very clearly that they are putting guardrails and tightening up the ability for Medicare Advantage plans to deny basic benefits using criteria that are not mentioned in basic Medicare coverage. And that language is extremely important because interqual, milliman, obviously these are not referred to in Medicare coverage policies. So NCDs, LCDs, and the regulatory language, they're not, they are proprietary, they are third party, and they are often what is cited to deny Medicare coverage, especially in the inpatient versus outpatient setting. And so just recognize that they are saying that they did not intend that. Where they felt that third-party criteria could potentially be used, or for anything that's deemed to be a supplemental benefit, so the add-on benefits. So if it's an extra benefit for the service or the payment of it, that is where when there was not coverage criteria, if they were adding more coverage or paying more than what Medicare would pay, that they would be able to employ third-party criteria. And they also tightened up the language about the oversight of this. So, and that they would have to make it publicly available, similar to the way this rule has to go through public comment. They didn't put it to that standard, but they did say it would have to be publicly available, peer-reviewed, et cetera. And so in some ways, it's really important to realize that the language we've been talking with the plans, in my mind and the way we read this, it sounds like Medicare is listening, that really the language we should be talking about is the basic Medicare coverage criteria. It should not be whether or not they met interqual or milliman. It should be for whatever service you're talking about. It should be going back as if you're doing a government audit and you're responding to a government audit. You should be talking about the Medicare coverage criteria, which we believe and we feel like they're codifying by including in the basic benefits that would be the 2 midnight rule. However, they did not directly come out and say that or give an example about that. So next slide. So again, just that point, we do believe that this means that the Medicare coverage criteria is the floor for coverage for Medicare Advantage. And they are absolutely clear that the OIG, and they state this, they said the OIG pointed out that we were not specific about whether or not coverage criteria that are different than Medicare coverage criteria are allowed or not. And what I have heard plans say is that they're not more restrictive, but they're more specific. And so in the plan language and the payer language that we're used to hearing, these interesting, I call it payer innovation of maybe wordsmithing, but the idea that you could be more specific and then deny care and not be more restrictive, Medicare CMS is being very clear that they do not allow in what they're proposing in 2024, which is reinforcing what they meant from the 2000 rule, is that they cannot be more restrictive or use as a reason for denial criteria that is not included in the Medicare coverage criteria in NCDs, LCDs, or regulatory coverage language. So realize, I think we have a bigger argument, and I think part of what we can do as a provider community, because they keep talking about receiving overwhelming provider feedback. What we can do as a provider community is make it clear that we want this to be overtly stated. Give an inpatient example of and I think what to focus on when you're giving your comments is about recommended prolonged observation for what should be a Medicare covered inpatient benefit. So the QIO and the QIC have been using Medicare coverage criteria, and if you go to the appeals websites, that you can basically see the outcomes, which they started making public, I think it was in 20 or 21. You can actually do searches, and you can do a search for the inpatient denials and what happened when it got sent to the level 2. Usually it's for non-contractor providers, but it's also sometimes patients are initiating a dispute because they disagree with the benefit coverage determination that it didn't meet inpatient. And the language that the Maximus uses when they evaluate this, they'll see that it was day 3 of the hospital, it did not meet interqual, but then they'll say Medicare coverage criteria generally follows the 2 midnight rule. First midnight of care was medically necessary because of X, and second midnight of care was medically necessary, therefore reasonable for coverage under Medicare coverage criteria. So we are seeing more and more use of the Medicare coverage criteria for the external review part when this gets outside of the plan. And so realize, if you go and read that, that's the argument I think that now we can start using for when we deal with these, what will likely be a persistent use of these as we go through the interpretation of this new guidance. So are interqual and Milliman more restrictive than CMS? We all believe they are, and Medicare is saying that if it is being used as the reason for denial, it cannot be any language or criteria that's not included in the basic benefit of Medicare coverage criteria. So that's, I think, a really important concept. Again, if Medicare would have covered this and would have paid for it like this, then this is something, as a minimum, that should be the threshold we use to push back. So why has CMS allowed this for so long? Even when the 2 midnight rule went active, and I know Kendall had sent me some information just about some of the discussion period about applying the 2 midnight rule. I don't know, maybe they didn't understand the scope. I think clearly it was viewed a little bit more of a payment issue, and the hospitalization was the benefit. It wasn't whether or not it was inpatient or outpatient. In my mind, clearly they are now stating that the inpatient benefit, it is a benefit. And we've always been of that argument where we discussed with them. We feel like there's patient appeal rights that can be removed, and prolonged observation is just a real issue that we're seeing with Medicare Advantage, not with Medicare any longer. So why have they allowed it? I think that they are finally listening that this is a real problem, and I think it's the groundswell, the community physicians' input, and everybody responding to these types of public comment with your own examples of this type of behavior, and requests to have it absolutely clearly stated and explicitly using either the 2 midnight rule or the inpatient coverage criteria for Medicare. So where's the enforcement going to come from? That's often been our problem. The regulations are pretty good, and frankly, in the post-acute space, we're not seeing a lot of people denied for interqual and Milliman. What we're seeing is misinterpretation of the Medicare coverage criteria or just ignoring it. And I think that, again, the pre-benefit side of this and fighting these concurrent, getting it to external review, but there is now more focus on this and more groundswell of support coming about this. So the more we're able to get this out so that interested entities like CMS can understand it without passing on any patient information, but giving examples in your comments would probably help them understand the extent of this. And we've all seen really bad examples of 4-day MIs that they say can be in prolonged observation because of interqual and misuse of interqual. So where's the enforcement going to come from? We'll probably get into that. But next. So what should we do? I don't expect that tomorrow we're going to start having payers not quote interqual or millimin. And I wouldn't get into an argument on peer-to-peers. I would continue doing what you're doing. I would absolutely change my appeal strategy though and consider appealing final cases with the 2 midnight rule and Medicare coverage criteria, and also quoting that Medicare never intended through their original guidance for there to be more restrictive or specific coverage criteria for the basic benefits of Medicare. And remember, it's not just simply a payment dispute any longer. It looks like Medicare is saying they always intended for this to be the basic coverage criteria. However, now they're being more clear and more specific in response to the OIG, and it absolutely states that because the OIG said this, because of our feedback from our provider community, we're going to make this clarification and make it clear that we don't want them to be more strict on their denials than what we would expect with regular Medicare. So continue, to fight these. And I would say most of our contracts have as a basic tenet that that the plan will follow basic Medicare coverage criteria. It's a requirement of the plans when they offer these. And so I think being able to realize that we can't, they've made their clarifications, and it might not ever be perfect from any wordsmithing that some lawyers want to do on a payer's behalf. However, if you're not organized and start pursuing your dispute pathways in your contract, and even just 20, 30, 40 inpatient cases that you have that are 3, 4, 5 day stays that clearly would have met inpatient coverage criteria, bundle them up and send it in a dispute letter and see how the plans respond. Let them know you're serious. I don't think if we expect CMS to come in and arbitrate between our contract and why these providers or why these payers are doing this, they will not get involved with this. We can probably discuss cases or examples, but you really can't engage CMS to have enforce this with your contract. It's going to have to come up with the idea that we should be using, if it's covered by Medicare, we should use that same coverage criteria we use when we respond to audits or short stay audits or anything else, and we should be doing this in an organized fashion. And if everybody starts pushing back, then it will become harder and harder for the plans to ignore this. And hopefully, as this policy gets adopted in 2024, there'll be even more specific language, but I expect we're going to keep seeing it. So advocacy, education, and really hardwiring your dispute resolution. You're not canceling contracts. You're just pursuing a disagreement you have in the coverage determination. And if you can batch them and get lawyers involved, it doesn't mean you're threatening to cancel a contract. It just means you're resolving a dispute with a contracted payer that you're a contractor provider with. So tell your stories. The CMS Part 2 C&D mailbox, you can give examples, and I would just, give examples, blind the patient, blind the payer, and ask if it's okay. If they start dismissing cases when you're doing expedited appeals, say for inpatients, ask if it's okay and give the example. You don't necessarily, if they want to know the payer, then you can give them the payer, but ask them the question, are they allowed to do this, and give them examples. But we have to use our contracts to police this behavior. Next slide. So again, the other thing that we always forget about is the patient. There's a Medicare, I believe it's complaint monitoring system. It's something along the line of the name of it. But basically, if you're enrolling in a Medicare Advantage plan and you call 1-800-Medicare and complain about that my inpatient benefit wasn't canceled, and you're acutely hospitalized and you're concerned about you having it covered, they actually are required to respond to that in a short turnaround, and they're required to monitor it. And so it's a pretty effective pathway to get visibility to it. And also patients usually aren't, we probably don't involve patients as much as we should as a whole, but letting them know that this is a benefit that they are not covering like Medicare would. Again, don't forget, it might not be long before they're trying to get some other treatment that they're trying to get denied, or post-acute care that they might have denied because it's being more restrictive. So getting used and making this part of our DNA that we have the patients also call and complain, it actually will raise awareness, and also will raise awareness of the plan's compliance team, because they're the ones that have to close this complaint. And then do everything we said as providers. We need to just hold our ground on the 2 midnight rule. I think it's a good level set, and it's the basic benefit now, and they're making it clear. So getting away from this irrational, various criteria-based discussion and getting into what the Medicare coverage criteria really is the way that we need to do this. And we need to coordinate it amongst our own organizations so that you are ready to fight this inside your organization. Remember, you do have a responsibility to resolve your disputes with the plan and not take it, externally if you're in a contracted relationship, depending on, if it's not a benefit, if it's actually a payment issue or a claim issue. But nonetheless, you can organize that internally around the concept that Medicare is listening to this and they're providing more oversight. So give CMS examples, and in your letters that you're going to submit, hopefully in mass, because CMS said overwhelming feedback that they've gotten. So we should continue that overwhelming feedback. Well, we do expect that they won't admit any wrongdoing, and that this is kind of new guidance. Again, we don't expect the behavior to change on this. Even if this goes into policy, I expect, we know the regs have often been good and plans kind of ignore them. If you don't challenge them, though, they will continue. And so if this does continue, we need to challenge them and realize that, just what we might see in response to this is we might see the same amount of inpatient denials, and they just won't quote Interqual or Milliman. So similar to how a 3-discipline rehab stroke, a stroke that needs rehab, we get that doesn't meet Medicare criteria. One plan is denying at a rate of 75% of our rehab referrals are being denied now, and we appeal and 88% of them are overturned. That same plan 4 years ago used to approve 95% of them on first pass, and they always quote Medicare criteria. So the idea that they have to quote Medicare coverage criteria, don't think that that's all of a sudden going to make them realize, oh wow, this is a covered benefit. I think we knew all along that they were using this as a reason to deny coverage. It certainly will be, they'll have to use language from Medicare coverage now instead of Interqual and Milliman. And so I think if they continue to do that after this rule is adopted, you should call them out on that, because this rule is pretty specific that they can't. But we shouldn't expect not to see the same behavior we see with post-acute care. I don't see Interqual and Milliman being quoted. I see Medicare coverage criteria being wrongly quoted for the patient's situation. And so expect that on the inpatient side, but at least it's more easily identified, and the level set will be Medicare coverage criteria. The denial activity of third-party reviewers, we realize how, even for clinical validation, interpretations of sepsis 3, half of these things usually meet the criteria they're quoting, and they just say they don't meet it, even though they can say, we had an MI on day 4 and then didn't meet Milliman because didn't have any signs of myocardial ischemia. So, we know that the criteria isn't going to matter as much as just, stick to it. If it met it and it met Medicare coverage criteria, we don't expect the behaviors to change a lot, but we do have more grounds to fight. So like we've said, we've been heard. This is huge. We've been heard, and I know a bunch of us have been fighting this fight for a number of years, and even had listening sessions with CMS. And I think people, they didn't understand how their oversight wasn't working. And I would say that, with the last OIG, where they, deemed that 13% of benefits weren't covered and 18% of payments weren't covered when Medicare traditionally did, OIG didn't even call it out, but nobody asked what happened on external review of these. Every benefit denial, if you should have been sent to an external review, and if it was appealed. And so if it was upheld, how come they weren't being overturned? How come the data from that? But they are going to now, especially for authorizations, they're really beefing up that they are going to have more data on the outcomes of authorizations and the use of authorizations, prior authorizations. So they are listening. They are listening, and I think it has been heard that they know Medicare Advantage is not covering what Medicare should. And so we just need to keep working from that idea. If Medicare covers it, that's the premise. We shouldn't feel like the plans can make up these own rules. That's the takeaway. They are coming out and saying they can't make up their own rules for basic benefits. They can for anything above and beyond what Medicare would cover. Dental, let's say they want to provide inpatient care on a one-night stay when Medicare wouldn't. They can do that. They can't deny the basics of what Medicare does on the floor of what Medicare covers.
All right.
Excellent.
Great. Thanks, Dr. Moore. Let's move on, Kendall. Dr. Kendall Smith is going to talk a little bit more about CMS and their definitions of medical necessity and what's on the rule book. So, Kendall, you're up.
I'm going to push pause for a second and emphasize something both Dr. Moore and Denise Wilson had mentioned, which was the impact of the talks that we had in August on subsequent comments. We know that before the webinars we did in August, there were about 500 comments registered with CMS. In the month that followed, there were well over 4,000. I can't attribute all of them directly to this webinar, but I'd like to think that this started the awareness. So if each of you attending today can work with people in your department to submit letters individually, the overwhelming number of responses, I think, is what led in large part to what we're discussing today. And one of the things, and I'll talk with Bill here and just Bill Haynes here just a minute about administrative rulemaking and the fact that the government believes, in his opinion, and I've come to understand as well, that they've already answered this question, and I'll show you 10 years ago, and even before that, this question's been answered. So in terms of medical necessity as defined under a traditional Medicare benefit under Part A or Part B, it's pretty black and white and nebulous at the same time, using the words reasonable and necessary, which aren't subsequently defined. So there's a lot of wiggle room in that. Denise, if you want to move forward to the next slide. The 2 midnight rule was introduced in October of 2013 to combat prolonged observation periods. Ironically, what we're dealing with a lot of Medicare Part C providers right now, subsequently amended in the 2016 Outpatient Prospective Payment System final rule. So that was 8 years ago. And under the 2 midnight rule, as we all know, if the stay was anticipated to span and actually did span more than 2 midnights, inpatient care was viewed as reasonable and necessary in combination with the prior slide of the definition of benefits under Social Security Act. So that those 2 slides form the basis of coverage for inpatient under Part A and or the need for observation, the determination of observation services under Part B. And you contrast that with the next slide, which comes from CMS a decade ago. So we are having the same conversation in almost 2024, 2023 that CMS answered a decade ago. And this is why my discussions with Bill, and Bill maybe you can weigh in at the end of this. And Dr. Moore just briefly mentioned that a Medicare Advantage plan may choose to cover inpatient stays that are shorter than those anticipated by the 2 midnight rule, essentially, but they can't go on to deny anything that would not otherwise be covered. So this appears to have been answered previously, at least in CMS's mind. Bill, do you want to comment on why we're still, to this day and age, in the midst of dealing with this?
Sure. The answer to that is this is a question that could have been answered with a yes or a no. And you'll notice that the answer is actually that very long paragraph. And do you know what fits into very long paragraphs like that of regulatory language? Lawyers. Lots of lawyers can fit in there. And lots of lawyers can find arguments for why this doesn't mean yes. It means something else, or maybe it means no. That's ultimately the issue, in my opinion, with this sort of answer. I'm sure the people at CMS thought that this was very clear. The problem is very clear would have been yes. That would have been clear. This allows for a lot of analysis and legal language picking, which is what, as a lawyer, this is what we're paid to do. I'm paid to do it for Payer Watch, which works for providers, but the lawyers who work for payers, they do that for the payers, and they can take an entire paragraph like this and absolutely tear it apart and make you think by the end that it means something completely different from what the clear intention I think we all believe is. But the problem is the answer should have been yes. That would have made things clear. And that is a difficult thing to, parse. But a whole paragraph like that can be parsed.
And that's the goal. The questions that Denise is going to put up and suggest that the folks listening to this and the folks that you work with submit to CMS is to put CMS on the spot to answer the question specifically yes or no. Or we're going to end up with, if you want to go to the next slide, ongoing issues like this. How did we get from the traditional definition of inpatient medically necessary care to this definition? Dr. Moore had pointed out earlier that they can't be more restrictive. Yet we've got guidelines like this and denials like this that are occurring on a regular basis, citing third-party guidelines contained nowhere in federal statute or CMS rules. Mention nothing about length of stay 2 midnights. Use ambiguous language. Define severe abdominal tenderness. Is that 8 out of 10, 10 out of 10, 6 out of 10? Does it require IV dilaudid? There's a lot of vagueness in this language, loopholes that can exist in these templates and guidelines that we know are very difficult and frustrating to argue against. The payers end up having the last word with these. So we want these things to go away, to stop the insanity, to get a simple yes or no question to the idea of the 2 midnight rule, definition of medical necessity, under Medicare Advantage being no different than if you were dealing with a traditional Medicare patient. So that's going to be the goal and the focus of the comment period between now and February 13th, which I think Denise and Bill are going to get into here with you.
Right. So I'm going to let Bill talk to us a little bit about a little bit more detailed legal language, but I will, when he's finished, I am going to talk about how you can present your comments or respond back with your comments to CMS, and then we will open it up for, not open it up, you guys, if you have questions, you're putting them in the question section, and that's great. We will address those. So Bill, tell us about some of the legal aspects of
Yeah, so this is
we're
mainly
talking about.
to give you just a little bit of a background and understanding of what is happening legally in terms of administrative law. Administrative law is an entire, its own section of law. On the federal level, it mostly deals with a statute called the APA, the Administrative Procedures Act. And different documents have different levels of legal weight. So at the lowest level, you have what are called guidance documents. And here's a formal definition taken from a document from the Justice Manual from the Department of Justice. But the main thing to understand about guidance documents, and all of the CMS guidance manuals would fall under the definition of a guidance document. A guidance document is just a way for an administrative agency to tell the public, and mainly the parts of the public it deals with the most, how it interprets its own rules and policies and procedures. But as you can see in the second point, these documents do not have the force and effect of law. You are never forced by lawful coercion to follow these guidance documents. However, practically speaking, you do have to follow them if you want the agency you're engaging with to actually do what you want, because this is their way of telling you this is what we expect. Now, okay, go to the next slide. But of course, if they try to argue about that in court, a guidance document doesn't have the weight of law, and they have to convince a judge that it should be taken seriously. And that's why a lot of things are turned into rules, and that's with rulemaking. So administrative agencies have the ability to create law, real law, with the real weight of law through what are called rulemaking procedures. And these are allowed through the APA and through the empowering documents of the administrative agency. And rulemaking is just whatever process they use to make rules. Generally, this is the notice and comment rulemaking outlined in the APA. And then the rules they create are also called regulations. Those terms, at least in federal administrative law, are completely interchangeable. And the main difference is rules and regulations, those have the force of law. So, okay, go to the next slide. So this is where it's important for this particular proposed rule. A lot of the language, particularly when it comes to the use of third-party guidelines and coverage, the idea that payers must cover basic coverage and follow NCDs and LCDs, those were in the guidance documents before. Now that language is going to be elevated, assuming this rule goes into effect, elevated from guidance to rule. So what does that mean? That means it will have more legal weight. People, including CMS, but other parties as well, will be able to say that if they're saying that the payer is violating this, they're not just violating a guidance, which doesn't have the force and effect of law. They're violating a rule that does have the force and effect of law, something they have to follow rather than something the agency has a very strong suggestion that they follow. Now, as has been said, this is unlikely to change payer behavior in the short term, and I think it's simply because they are already comfortable in attacking claims made under this language, and so I don't think they're going to immediately change simply because the language now has rule next to it rather than guidance next to it. But in the long term, and this is to reiterate particularly what Brian and Kendall have said about the need to push back, to use this as a tool. In the long term, this should help with the non-contracted, Medicare Advantage appeals you do, arbitrations you do under contract, or litigation that's done in either situation, because the language that is there has much greater weight now. And I think particularly the descriptions of the reasoning given by CMS that Dr. Moore pointed out, like all of that can be brought to bear in a stronger fashion when you get to those levels. But as he mentioned, this is something that we're going to need to push on, because otherwise, the fact that they've elevated guidance language to rule language by itself, that's not going to win the battle. But it helps making that language stronger when you actually get in front of an ALJ, of a judge, when you go to the Medicare Appeals Council. That is where it will help. Yeah, so next.
Okay. Yeah, great. Thank you, Bill.
Mm-hmm.
All right, so I'm going to talk about how you submit your comments to CMS. And let me just clarify one thing to you all. I think I said at the beginning of the webinar today that we were going to continue this conversation on February 1st. We're actually continuing it on January 31st. It's a Tuesday, January 31st. So I just wanted to clarify that. And I've got that information at the end of the slide set today as well. So how do you submit your comments to CMS? So there's a link. Again, it's a very long link to go to where you submit your comments. But you can also, as I said, just search CMS-4201-P, and you should be able to find the web page where you submit your comments. You are filing a document into official docket, so please, any personal information about yourself included in your comment text and or uploaded may be publicly viewable on the web. It goes without saying, do not put any PHI in your comments that you're submitting. You can talk about cases that you have had personal experience with, but no PHI. So this is what the page looks like. So this is how you know if you got to the right page. And I have circled there where you submit a formal comment. You just click on that green link right there, and that's where you submit your comment. Now, you can read the comments once CMS has reviewed them and published them on this site. You can go to the site and you can read other people's comments. It usually takes them a little bit of time to get them up there. The last time I checked, it says there's 3 public comments, but actually they're not viewable yet at this time. So it will always give you a running total of how many comments have submitted. You can't always view them at that time that you're visiting the site unless CMS has already reviewed it and released it for public viewing. Again, you have until February 13th, 2023 to submit your comments. Okay, so I'm just going to go through if the 4 areas under provision E that you may want to comment on. Obviously, you can comment on anything in the very large proposed rule, CMS 2024 proposed rule for Medicare Advantage, but these are the 4 that we have talked about today or we'll be talking about on January 31st. And if you download our template letter for you to submit your comments, you'll see these 4 are in that template letter, and there's a place for you to comment on each of them. And obviously, you don't have to comment on all 4. If you don't have anything to say or any thoughts or any concerns about number 2 or number 3 or whatever, you know, you don't have to submit your comment. This is for your use. So the 4 areas under provision E, and this is straight from Medicare's proposed rule, this is their language, is 1, requiring MA plans to follow traditional Medicare coverage, which we just talked about. Number 2, requiring plans to provide a public summary of evidence that was considered during the development of the internal coverage criteria used to make their medical determinations. Number 3 is required an approval granted through prior authorization process must be valid for the duration of the prescribed course of treatment. And if an enrollee changes from one Medicare plan to another MA plan or from traditional Medicare to an MA plan, there's a 90-day transition period. So that's a protection for our patients. And then number 4 is to require MA organizations to have a UN committee. What about that? Led by a medical director. And keep policies, review policies annually and keep current of LCDs, NCDs, and other traditional Medicare coverage policies. Well, I hope they're doing that already today, but I guess, you know, if they codify this, then that would be something they would have to, that they're going to have to do, for sure. So make sure you make your voice heard, as all of our panelists said today. We are being heard. It requires a groundswell. It requires all of us to comment back to CMS, to make sure that we're using our active voice, you know, talk about how you feel that Medicare Advantage organizations have been unfair or unjust in the past. Use examples if you can. No PHI, and then use the word template if you'd like to. We're providing that for you attached to this presentation. This is what the page looks like when you go to submit your comment. You can type in your comment under the big white field there at the top, but there's also, you can add your comment as a file. So you can upload your Word document or whatever format you have your comment in, you can upload it. I think what I did for the association last year when they asked for requests for information is I put just an introduction under the comments of who we were and why we were submitting, and please see attached file, and then I added our longer document, which was our comment about the MA plans. They also asked us, what is your comment about, which I think is a little bit strangely worded. Your choices under what is the comment about is to choose if you're a physician, a nurse, a hospital, are you representing a hospital or other healthcare professionals. So they give you a long list of choices there to select in that drop down. Upload your file. Consider adding an example of an egregious denial letter, other payer correspondence that supports your comment. Because that may carry more weight if there's a specific example that you can cite. I think we said that multiple times today. These are the different file types that they will accept and the file sizes. Email addresses are not published on the Federal Register site. There is an option to receive email confirmation of your submission. I would suggest you do it. I would recommend you do that. It was nice to know when they emailed me back and said they received it. They also emailed me and told me when mine was posted, and they gave me a tracking number. So if I ever want to go back and read my comment, I can go to the site and put in my tracking number, go right to the comment that I submitted. So I think it's a good idea to opt in to receive your emails from them. So create and submit your comments by February 13th. Use your active voice, real scenarios without PHI. Download the template from this webinar. It should be on your control panel. Or if you're not able to download it, you can also get it off of our website. ahdam.org, or you can email me directly at dwilson. I'm sorry, that's the wrong email address. I just caught that. It's actually denise@adam.org, denise@adam.org, so denise@adam.org, if you want the template. If you do dwilson@adam, I don't think it'll go anywhere. Sorry about that. Okay, and then if you have any further questions after the webinar today, you can send them to Kendall, Bill, myself, and then you can also register for the January 31st session at adam.org or payerwatch.com. All right, so we're did great on time. Let's go back and look at some of our questions, and
Denise,
I'll just throw them out to you guys and
Denise,
see who
I
wants
just
to answer them. Go ahead, Kendall.
to the folks that are listening, if you're part of a department and are planning for the department to submit individual comments from a template, that CMS, the government, will tend to look at identical letters. So if you part of a department of 20 people and you send 20 identical letters in, it's going to appear as one comment. You want to individualize those letters. You may raise the same point in the letter, but they need to appear to be unique in some fashion, so as not to be counted as just a single comment.
Can I say something to add to that too? I think, the hard part is that everybody wants to kind of write this beautiful, regulatory kind of overlay on why this is good. Don't forget, if you're just a practicing physician advisor and you're tired of dealing with this, de-identify a couple of your worst, denial letters that you had to appeal and got upheld, showing what you're dealing with, and say, please codify the two midnight rule. Like, you can be pretty simple, but I honestly think the more you show them examples, real world examples of a 4 or 5 day stay. We've had 4 or 5 day stay that, they said denied for for Milliman because never went to the OR, even though in the body of their denial letter it says went to the OR on day 3. Like show them those examples, and to me, as long as I wouldn't be mentioning a specific plan. I know people can, whatever, but I would just be letting them know how pervasive this is. And this is medically necessary prolonged observations being substituted for inpatient care. So highlight that, give them real world examples, and the more of us that do it, even if it's a few cases from a lot of people, I think that is better than doing some form letters. But I think that making sure you give your particular experience.
Okay, so Lori says, I have Medicare Advantage plans that state that inpatient admission exceeds the member's needs and therefore it's not medically necessary, would not be covered by Medicare.
So is that in any Medicare coverage criteria, that it exceeds the patient's needs? I think what they're saying is it's medically not necessary, but they're just not giving you a reason for it.
Right. Eileen says, if this is finalized, will this impact take place in 2024, or is it already codified? It's going to take place in 2024, right? I'm pretty sure it says calendar year 2024.
The clarifications will be taking place in 2024, but the clarifications, they trail all the way back to 2000. So I'm not about what their intent was, but I think they're saying that the additional guardrails for them to be more restrictive and preventing denials is going to be for 2024.
Okay, so someone, let's see, Eileen also says they're using strong CMS and OIG recent language in their appeals since December 27th, 2022, which is when the proposed rule was published. So far, she says most of their Medicare Advantage denials are remaining upheld, and they're in the process of submitting second level appeals now. So that's good to know. Someone's has already taken what was published at the end of December and using that in their appeal. No change in payer behavior yet. Not really too surprised there. Okay, let's see. Can an insurer's, Rebecca says, can an insurer's own policies be considered third-party criteria, as was mentioned towards the beginning of this presentation? I think this goes back to the discussion we were having about, you know, the NCDs, the LCDs, if there isn't one present, then the Medicare Advantage plans organizations, they can create their own policy bulletins if there isn't an NCD or an LCD. So would you consider that, it's not really I wouldn't say that's third-party criteria.
It's not technically
it's medically necessary criteria.
Yeah, but it would fall under, because they basically said third party or proprietary. So that would include stuff created by the payer themselves.
Okay.
Yeah, and they prohibited using language to deny that's not included in Medicare coverage criteria.
Yeah.
For basic benefits, which now they've established inpatient hospitalizations as basic benefit.
Okay, we have, Karen says, we have MA cases that have been to peer-to-peer reviewed and approved, but now being audited by third parties for denial. Is this really appropriate? How do you handle that?
I mean, we certainly don't think it's appropriate,
No.
but it does happen. And it might be, if you're contracted, it might be allowed in your contract. That's one thing. That's why contracts, you have to be very careful about how they're negotiated, and you need to pay attention to what's in them. That might be allowable if your contract says it's okay.
And if you're not contracted, you have full appeal rights. And if you had a authorization granted, if you're non-contracted for that service, then they shouldn't be able to go back and do a retrospective audit for what was approved.
Yes.
They can do anything inside of your contract if you, Denise, they can do anything inside of your contract, your contractual relationship, if you allow them to. Like, don't expect them to know your contract, and don't expect them to, I mean, if they're wordsmithing this, right, the inpatient benefit, don't expect them to know your contract, and don't expect them to stop doing something with just a simple verbal request.
Yeah.
Good advice. Okay, so this is a good question from Heather. How do we know if our MA plan is sending our denials to the IRE review like they're supposed to? How do you know if they're actually sending them on?
Good. What? Kendall, you want to? They're not. They're only supposed to if you're not contracted, and so in other words, they are allowed to do a denial. Now, if you do a patient, and if you're contracted and you do a patient expedited appeal on behalf of the patient, then you're appealing the benefit, and there is stronger language that can prevent that from being dismissed, but it's still being explored. So it won't go to the independent review unless it's a pre-service benefit denial or a concurrent service benefit denial. But if you are not contracted, by definition, once it's upheld and you've appealed it, and it was upheld at an appeal, not a peer-to-peer. Peer-to-peer is just exchange of information to get the off. That's not an appeal. People need to understand that. It's a way that you can correct the initial off, right? If it gets upheld at if the off gets denied, and then you do an appeal, the internal or the external review entity comes into place if you're not contracted and you do the first level appeal. It's supposed to go right to the external. So, and you'll know because you'll get contacted by it. If you're not getting contacted by the Maximus or whoever is doing it, depending on what it is, it's not happening like that.
So there's not,
way to track, Ryan, online whether that referral has been made. So there's a presumption that it has to happen, but absent getting the confirmation from Maximus, I don't know of an online resource where you can actually track with the patient identifying number to see if it does in fact exist.
You can call, like if you, I mean, you'll get a phone call, like if you're the party that's appealing it on behalf of the patient, you'll get a phone call acknowledging receipt of it. If it's expedited, you don't really have a window that you can submit additional information. The plan submits all the information, but you should have some correspondence, or whoever is appealing it should have some correspondence that it went. And we definitely know, as I mentioned before, about the what used to be termed a payment dispute by MA plans was clarified in 2020 after some advocacy that they cannot, the plans for non-contract providers cannot reopen or downgrade a payment or do anything without giving full appeal rights. That should all, if you're non-contracted and you appeal, if the appeal is upheld, again, not a peer-to-peer, but an appeal is upheld, your level 1 is upheld, that should automatically go to the IRE.
Okay. All right. Okay, so someone, let's see, Jack mentioned that MA plans are requiring peer-to-peer review and setting a specific time frame, like 2 hours. If the physician does not call, then they deny the claim. The insurance justifies the start of the time by voicemail as an allowance to start the clock. I think they're just talking about some peer-to-peer processes that.
Yeah, so peer-to-peer is not a requirement in the regulations. However, you might have contract language that says that plans have to make their staff available to discuss the denial within a certain period of time. Often those are older contracts, and it was on the model of people being, in your hospital, or that you could discuss it within 24 hours. But basically, just recognize that they can make up the rules around it, because it's essentially an auth request. It's a way of exchanging information for an auth request. So there's some plans that just won't do a peer-to-peer. And if you have, but realize that doesn't mean you don't have expedited appeal rights. If you're representing the patient, you want to try to do a expedited appeal, you can just fax in an expedited appeal. But if they don't want to, or they make it hard to do the peer-to-peer, unless you have something in your contract, you can try to find out what their policies are, because they should be applying that in a standard fashion. The big plans usually have rules around it, but it's very hard to do peer-to-peers if they really don't want to do them. There's no requirement in the regs for peer-to-peers.
Okay.
Might be for some of the NCQA or the other certification bodies. Yeah, that's something you can look into.
Okay, a couple of folks asked about part 1 of this MA discussion. So you may have seen in the title for this webinar, this was labeled as part 2. We did do a couple of webinars. Did we do 2 webinars, Kendall, or just the one with Dr. Moore back in August? Yeah. That was recorded, and you can find that on either the recording on the Adam webinar, the Adam webpage, or the PayerWatch webpage. Okay, adam.org or payerwatch.com. The recording is available for free to watch on either of those websites. Okay, Deborah makes a good point. She says their organization is pretty successful overall in overturning MA level care denials upon appeal, but as a provider, they're having to expend an unreasonable amount of resources to ultimately get these approved. So she says she thinks it's important to mention this in your comments to CMS. The issue is causing undue burden to providers.
Yeah, I absolutely agree.
Okay. All right. That pretty much sums up all of the questions. I did pass over some questions because they're a little bit more in-depth or detailed. We will do our best to try to get you a response to those questions in the days going forward. I want to thank all of our attendees today, Dr. Brian Moore, Dr. Kendall Smith, Bill Haynes. Thank you so much for everything that you mentioned. Please make sure you do your comments. Reach out to me if you have any questions about how to do that. And make sure that you register for the January 31st session. We will continue this discussion with Dr. Eddie Hugh as our guest. So thanks, everyone. Have a great rest of your day, and we will see you on January 31st.
Thank you. Thanks for organizing.
Thank you. Thank you, everybody.
Thanks, Denise. Thanks, Brian and Bill.
Thanks, both of you.